Chapter 33, the urinary system. Lesson 33.1, urinary system theory objectives. Illustrate the anatomy and physiology of the urinary system. Differentiate the causes of urologic problems and disorders. Discuss ways in which the nurse can help patients to prevent or cope with urologic disorders. Outline the psychosocial impact of urinary incontinence. Compare and contrast drugs for urinary incontinence with those for benign prostatic hypertrophy. Clinical practice objectives. Identify nursing responsibilities in the pre procedure and post procedure care of patients undergoing urologic diagnostic studies. Perform initial and ongoing nursing evaluation of a patient's urologic status. Describe 5 nursing responsibilities related to the care of a patient with an indwelling catheter. Revise an existing nursing care plan for a patient with urinary incontinence. Structures of the urologic system. We have the kidneys, which are these bean-shaped organs that sit in the retroperitoneal aspect of the cavity. On top of each kidney, we have that adrenal gland that produces um, norepi, cortisol, and aldosterone. We have the inferior vena cava, which is our venous blood flow from the kidney. And we have our renal artery, which we get from the abdominal aorta, which brings our blood to the kidneys. We have um, the bladder. Now, the bladder is going to store the urine. Urine is produced in the renal um, capsule itself within the kidney and then comes down the ureter and is stored in the bladder. The opening of the bladder is called the urethra, and this is um, the opening through which we place the Foley catheter to drain the bladder. This is the kidney, the actual structure of the kidney. Here's that renal artery we talked about supplying blood to the kidney, and the renal vein taking blood away from the kidney, and the ureter, which is going to drain the urine from the kidney. Looking at the kidney itself, we have the fibrous capsule that surrounds the kidney, the cortex, the medulla, okay? We have the renal columns between and pyramids periodically throughout. We have the renal papilla. And then we have this renal pelvis region with the calyxes. And this is where we're going to drain the urine as it's produced, or excuse me, collect the urine as it's produced for drainage down through the ureter. This is the nephron. The nephron is the structural unit of the kidney. Okay, here is what's going on inside of the nephron. Um, we have the afferent arteriole um, bringing blood to the nephron or the kidney cell, right? And it ties up in this bundle of capillaries called the glomerulus. The glomerulus is going to enable filtration to occur. It's going to remove metabolic wastes from the blood that's coming into the glomerulus. Okay. And then the efferent arteriole is going to take the blood away from the glomerulus. And that's going to be the more purified blood. Okay. The glomerulus is going to filter out that blood inside of that Bowman's capsule, removing those metabolic wastes, and then they will go through the remainder of the nephron. The first section here of the nephron is called the proximal convoluted tubule. Water is absorbed here. Actually, quite a bit of water is absorbed here, as well as sodium is reabsorbed based on the action of aldosterone within the nephron. Okay, we're going to go down the proximal convoluted tubule and we will find the proximal straight tubule. Coming down the straight tubule, which is a portion of the loop of Henle, we will see we come up the other side. We've got some sodium balancing going on here, and we'll come up the thin segment of ascending loop of Henle and then the thick segment of ascending loop of Henle. Um, so lots of active transport of sodium out, water through the process of diffusion. We may see some come in, some go out. We're going to be balancing our sodium, our water, and our other electrolytes. Coming up that thick segment of ascending loop of Henle, we will see the distal convoluted tubule. We have lots of ADH effect right here in this distal convoluted tubule. Water will be reabsorbed through the antidiuretic hormone actions. Sodium, therefore, will also be reabsorbed. And then we will come down that distal convoluted tubule into the collecting duct where we produce urine. Functions of the kidneys. The kidneys work to regulate your serum electrolytes by filtration and reabsorption. They also eliminate metabolic waste by filtration. They regulate your fluid volume in your body by filtration, the reabsorption, and excretion, depending on what your body needs and what your hormones are telling your kidneys to do. The kidneys also assist in maintaining a good acid base balance by secreting hydrogen ions into the urine. They regulate blood pressure by secreting the enzyme renin. They increase red blood cell production by secreting erythropoietin. And they metabolize vitamin D into its active form. What about the other structural and functional units of the urologic system? The ureters, the bladder, the urethra. Well, the ureters are going to carry that urine from the renal pelvis to the bladder. The bladder is going to hold and collect the urine, and the urethra is going to carry the urine from the bladder during urination. The flow of urine is controlled by the internal urethral sphincter and the external urethral sphincter. The reflex of voiding is called micturition. The micturition reflex is initiated and transmitted to the bladder, allowing the release of urine. What are some disorders of the urologic system and their causes? Well, if you've got disorders, you may be infected. You may be vulnerable to infection. You also may be having an immune response or immune reaction inside of the glomeruli. There may be some kind of obstruction, like a tumor or a kidney stone, or some kind of anatomic feature, like an overgrowth or a stenosis. You may have tubular necrosis, which is a lack of oxygen and chemical destruction of cells within the kidney. You may also have high blood pressure, atherosclerosis, or diabetes mellitus, which can affect the urologic system. Compliance with treatment for high blood pressure and diabetes is very important to prevent serious damage to the kidneys. The minimum recommended fluid intake is 2 to 2.5 liters per day in order to sufficiently flush the urologic system and prevent the formation of stones. Bladder health is also very important. You need to regularly drain the bladder and never hold urine. Controlling blood pressure will help to prevent cellular damage. And there are some medications that can cause nephrotoxicity, so we need to be aware. Diagnostic tests and procedures. A urinalysis and culture may be ordered, as well as a sensitivity to antibiotics. A complete blood count may be ordered, especially if an infection is suspected. Blood urea nitrogen. Urea is produced when protein breaks down, and then it combines with ammonia and is carried by the bloodstream to the kidneys for excretion. And then within that glomerulus, the BUN is removed from the blood and effectively placed into um, the nephron for excretion, right? It's going to go through that whole process. Creatinine is a byproduct of skeletal muscle contraction, and therefore it is also a metabolic waste. BUN and serum creatinine are interpreted together, and the lab values should be obtained before the use of any kind of radiologic contrast dyes. Because if we have really high levels of BUN or serum creat, we're concerned that the kidneys are not functioning effectively, and therefore we do not want to further stress the kidneys with contrast. Creatinine clearance is a good measurement of glomerular filtration, right? To see if it's doing an effective job. So we might do a creatinine clearance, we may do a GFR, right? And we would want that rate to be high, which would say that the kidneys are filtering at a very high rate, not a low rate. Um, there's also a newer test called the cystatin C. It's a test used to evaluate glomerular filtration rate as well. Cystatin C is a low molecular proteinase inhibitor. It's produced at a constant rate, and therefore it's very easy to track how well the kidneys are doing because the waste, or excuse me, the um, uh, inhibitor is produced at that constant rate and not with excessive production with exercise, etc. And with impaired kidney function, we may see those cystatin C levels start to rise as the kidney struggles to excrete that excess waste. The normal value for cystatin C is zero point 0.7 to 0.85 milligrams per milliliter, just depending on the patient's age. The diagnostic test will show promise of being, or has shown promise of being, a better indicator than creatinine clearance. However, because the urologists are very happy with the creatinine clearance and BUN as good indicators of kidney health, it's been a reluctant transition to using this cystatin C. BUN level and serum creatinine are the two most commonly used tests to screen for kidney problems. A normal BUN is between 10 and 20 milligrams per deciliter, and a normal serum creatinine is between zero point 0.6 and 1.2 milligrams per deciliter for men and zero point 0.5 to 1.1 milligrams per deciliter for women. An increase in BUN or serum creatinine can be a good signal or sign of decreased kidney function. We may also do KUB radiography or kidney ureters bladders. If you ever, or excuse me, kidney ureters bladder, you might hear of people call them KUBs, and that is what they're talking about. It's just an X-ray of the abdomen in order to locate stones or detect any kind of structural abnormalities that may be causing the symptoms. Um, Angioplasty may also be used, especially if we have blocked vessels that that would help to reperfuse flow to those organs, specifically the kidneys, right? And then urodynamic testing. Urodynamic testing, like cystometrography, is used to measure flow volume and muscle function, especially if a patient has a history of incontinence. We may do some urodynamic testing to see what the actual failure is or leakage. Biopsies of the kidney or bladder may be done in combination with other radiologic exams to locate lesions on the kidney and be more diagnostic for potential neoplasm. Renal biopsy. So this procedure is done. The patient is lying down, and we use a needle. We insert it through the skin, and we take a small tissue sample from the renal capsule itself. Okay, we're going to talk more about this in lecture. Just be aware that the renal biopsy is a procedure in which we're looking at the tissue of the kidney. Changes in urine output and flow. There are many different conditions or characteristics of urine flow that have specific names. Anuria, for example, is the absence of urine. It is extremely rare. However, if a person has AKI or acute kidney injury and is in acute renal failure, we may see no urine produced. Oliguria is much more common. This is the diminished or abnormally decreased flow of urine. It may be caused by dehydration, renal failure, or some kind of obstruction. So your dialysis patients are typically oliguric. They produce very little, if any, urine. Polyuria is abnormally high amounts of urine, dilute urine, right? It's usually the result of excessive solutes and increased excretion of water. If a person has hypercalcemia, diabetes insipidus, uncontrolled diabetes mellitus, or they've just been taking in a ton of fluid, we may see polyuria. We also see polyuria in pregnancy. Nocturia is urination that occurs at night. It may be related to the decreased ability of the aging kidney to concentrate urine, and therefore we have um, large amounts of dilute urine produced 24/7. Urinary frequency is voiding more often than every 2 hours. If you have some inflammation, infection, decreased bladder capacity, any kind of psychological disorder, or you're just taking in a whole bunch of water orally, you may have urinary frequency. Urinary hesitancy is a delay in the start of the stream of urine. This can be related to a partial obstruction due to a kidney stone, but it also may be due to a pretty normal or common effect of aging, which is the enlargement of the prostate in males. Urinary retention is retaining or holding on to urine in the bladder. There's all different kinds of causes for urinary retention. It could be a psychological cause, specifically with young children. They don't want to use the restroom. It could be neurologic in nature. Maybe there was a spinal cord injury and therefore there's no innervation to the bladder. Um, it could be a medication side effect. It could be as a result of obstruction, such as a stone, or it could be post surgical, maybe due to swelling. There may be residual urine as well. This is urine that's left in the bladder after voiding related to the poor muscle tone or partial obstruction. So the person is not able to fully empty their bladder. Common causes of variations in the color of urine. So we need to talk about what can cause each of these colors of urine. So colorless or pale yellow urine can be caused by increased amounts of fluid, right? And then bright yellow, dark amber to orange can be caused by different medications. We're going to talk more about these types of medications in lecture. You could come prepared to lecture by really looking in your textbook about which kinds of medications would cause changes in the urine color. Pink to red, there are some medications that cause pink to red urine, but more often this is hematuria or seeing blood in the urine. Brown urine. This can also be a cause of medications, but often this is also blood or some kind of metabolic disorder. Blue or green. We see this a lot with methyl blue when we inject a dye into the bladder so that we can verify that we haven't nicked the bladder in surgery. And then dark brown to black can be indicative of failure. Um, Please come prepared to lecture knowing exactly which medications affect the urine in these ways. Characteristics of urine. Well, first of all, we note the odor of urine. If there's no odor, that's a good sign. That means there's probably not an infection. If there is an odor, it could either be due to a hyperconcentrated urine, due to dehydration, or an infection. Hematuria, we just talked about this. This is blood in the urine. It can either be gross hematuria, where we're obviously able to see that there's bleeding in the urine, it's pink or red, or microscopic, in which that we're only able to detect the blood under a microscope, right? And in that way, we would suspect things like a stone or some kind of occlusion or kidney injury. There also may be proteinuria or protein in the urine, including microalbuminuria. So we may see protein in the urine with various conditions of related to high blood pressure, specifically in OB. We see proteinuria in our patients that have preeclampsia. And then pneumaturia, and this is air in the urine. So we see bubbling. This could tell us a little bit more about our protein balance. It also could tell us about our hydration status. Voiding patterns, including urgency. Why do we have urgency? Um, this also could be related to infection or inflammation, but it also could be just a normal or expected complication of aging. Patient teaching. It's very important we teach our patients hygiene practices to prevent urinary tract infection. For our females, especially, it's important to wipe front to back in order to prevent um, contamination. And then we also want to teach both males and females to urinate after sexual intercourse in order to prevent bacteria from moving up the urethra into the bladder. Assessment of urinary symptoms. If there's pain and discomfort, we want to assess where that pain is coming from. So, is it a bladder pain, which would be more of a lower abdominal pain, cramping potentially? Or is it a flank pain, which is down the sides of the abdomen, more indicative of renal issues like a stone or a renal infection, right? Kidney infection. Dysuria is pain before, during, or after urination. So this is actually during the urination process is there pain. Principles of urinary catheter and tube care. So This is a repeated slide, unfortunately, and I will have to get you guys the correct information. It looks like it copy and pasted from the wrong area. So when we're taking care of the urinary catheter and the tubes, it's very important that we provide really good peri care, that we keep the urinary catheter low so that it can flow to gravity, that we make sure that there's no kinks or obstructions within the tube. Um, we may even have an order for irrigation where we're injecting water into the bladder and withdrawing it in order to dislodge any clots or any kind of secretion or buildup. It's very important that we keep the end of our catheter bag, collection drainage bag, free from bacteria. We want to clean that with an alcohol wipe before we replace it back into the bag following a drainage. We want to make sure that we're regularly emptying that catheter. It's very, very important to prevent over distension of the bladder or backup. Here's an example of catheter tubing. You know, you want it to be to gravity. You want to have it secured with a securement device, like a stat lock securement device for the urinary catheter. It's important that it is actively draining, and we could assess that by looking at the bag to see if it's collecting additional urine, and that we're regularly emptying it. Urinary incontinence. So there's some contributing factors to urinary incontinence, including just being in a institution like a hospital or long-term care center. We do see an increased incidence of urinary incontinence when your patients aren't able to get to the bathroom like they were at home, right? They have to push the call light, maybe they have a bed alarm, maybe they have bed rails up, they don't have their assistive devices within reach. So it makes it much more likely that they may have episodes of urinary incontinence. Women who have had several children have a increased incidence of incontinence due to muscular tone. Right, we know that the tone is decreased, and therefore the woman is not able to control her um, reflexes as well. That especially the external sphincter may be dilated, allowing some leakage. Men with a large prostates are at an increased risk for urinary incontinence as well. They're not able to fully drain the bladder, therefore they're more likely to dribble. Other contributing factors, including spinal cord injury, neurologic disorders like dementia, functional disorders like difficulty manipulating their clothing fasteners, may result in urinary incontinence. So, wherever we can intervene here, whether getting them on a bladder, toileting schedule, or a catheterization schedule, or just making sure to give them constant reminders to use the restroom, or providing adaptive devices for their clothing, like using a drawstring versus a button on a pair of pants. There are many different types of incontinence. Excuse me. Urge incontinence is that involuntary loss of urine where there's a strong urge to urinate right now, right now, right now. And this results in leakage. Stress incontinence occurs when that urethral sphincter fails and there's an increase in intra-abdominal pressure, maybe sneezing, laughing, coughing, exercise. Whenever you've increased pressure within the abdomen, you're going to put pressure on the bladder. And if that sphincter is not able to withstand the stress, then you have incontinence. Mixed incontinence is where you have a combination of different types of incontinence, maybe stress and urge incontinence together. Overflow incontinence occurs when there's that poor contractility of the detrusor muscle or some kind of obstruction of the urethra, as in a prostatic hypertrophy in a male, or potentially even a genital prolapse or an abnormality in the female. Functional incontinence will be caused by cognitive inabilities to recognize I need to use the restroom, right? That urge to urinate is not picked up. There also may be a self care deficit, either caused by physical inability or maybe psychological depression. Inability to reach the bathroom because of restraints, side rails, out of reach walker can also result in that functional incontinence. And the last type of incontinence is that neurologic incontinence, and this is caused by disorders of the neurosystem, things like multiple sclerosis or spinal cord injury. So we need to be careful to obtain a really thorough history and physical. When we're getting our history on our patient, we need to report, or excuse me, get our patient report of symptoms documented very thoroughly, when their symptoms are occurring, what maybe uh, precedes these symptoms. Bladder diary, this is where the patient is documenting how often they're using the restroom, and just making sure to document any episodes of incontinence as well. Routine urinalysis just to make sure that we don't have like a chronic infection or any kind of issue like blood detected in the urine that may be indicative of a stone. Measuring post-void residuals, stress testing, urodynamic studies, cystograms, cystoscopy. These are all different ways we can diagnose an issue with urinary incontinence. Post-void residual, if we have residual within the bladder after voiding, we may have an issue with complete emptying of the bladder. Stress testing, this is going to have your patient bear down, cough, and see if they have any issues with um, uh, stress incontinence. Urodynamic studies can detect any kind of musculoskeletal issue or hypersensitivity of the bladder. And then cystogram or cystoscopy are going to give us a good visual of what's going on within the urinary system. How do we treat urinary incontinence? Well, stress incontinence and is handled very well with pelvic exercises. Things like Kegel exercises can help to strengthen those muscles and help overcome the stress exerted, the increased intra-abdominal pressure, which is going to compromise the sphincters. Vaginal weight training, maintaining a normal weight, and estrogen therapy are very important, especially for our postmenopausal women, in order to strengthen the muscles and the integrity of the tissues surrounding uh, the urethra. Medications may be given, things like ditropan, which can help with spasms. So these are antispasmodic medications. It also can decrease the frequency. Biofeedback therapies work very well in order to train the body to hold or excrete urine, depending on the situation. Implanted electrical stimulation devices, interstims, these are good for patients who have had neurologic disorder or injury. Penile urethral clamps can be used. Other occlusive devices can be used, especially if we have a external or excuse me a yeah, our external sphincter is causing issues. Transvaginal electrical stimulation or TES may be used in order to um, treat the incontinence. We also may do bladder injections in order to strengthen or harden the bladder wall to prevent spasm. Retropubic suspension, needle bladder neck suspension, slings like midurethral slings may be placed. We also may put in artificial sphincters through an implant process. As a nurse, it's just very important that we use a gentle and matter of fact approach when we're discussing issues of incontinence, that we are continuing to evaluate our patient for urinary incontinence and symptoms associated, that with our older adults, we're making sure that we uh, put extra care into making sure that they have their assistive devices within reach, that we have them on a good toileting schedule, that as we're doing our hourly rounding, we're doing our 4Ps, including potty if they need to use the bathroom. And when we have assignments in nursing, so when you get to the floor and you're given your patient assignment, if your patient is having bladder training as a regular part of their um, care, right? They're on a very fixed schedule, maybe a self cath or a utilization of the toilet on a very strict schedule. That's time consuming. And so when you're given an assignment, it's important that if you have a patient who is bladder training, that your assignment is not so heavy that you're not able to support them in that process. And then drinks and substances avoid. Obviously, caffeine is not going to be great for the urinary system as it's going to increase um, the stimulation of the bladder. Additionally, things like um, diuretic drinks like teas can cause you to urinate more frequently. Urinary retention. There's two types of urinary retention. There's acute urinary retention. We see this a lot after surgery, after the removal of a catheter, sometimes even with potential or certain medications. We see some urinary retention. With chronic retention, it's more anxiety or there's a neuro disorder or potentially even an obstruction that's causing the lack of urine flow through the urethra, like that enlargement of the prostate gland or a urologic stone somewhere. Nursing management with urinary retention. First, we have to evaluate the degree of bladder distension. How much bladder distension is going on? Why is there bladder distension? What precipitated the bladder distension? We need to provide privacy and adequate time for our patient to void. Also, have the patient double void. So use the restroom, and when they think that they're finished, go again in order to thoroughly drain the bladder. Um, Scheduling trips to the toilet is also very important, getting them on a regular schedule. Medications like bethanechol can be used in order to encourage regular emptying of the bladder. And then residual urine. We want to make sure that we can either cath it out or have that patient double void in order to fully drain the bladder. So you're going to assess the degree of bladder distension using gentle palpation before and after your intervention. You may also bladder scan your patient. Assist your patient by providing privacy and adequate time for their voiding. Whereas caffeine is bad for our incontinence, caffeinated drink may be very good for a patient that has urinary retention, as well as maybe a warm bath in order to stimulate voiding. So you have your patient with double voiding, you have your patient void and sit on the toilet for several more minutes and then void again. You try twice. Scheduling a trip to the toilet every 3 to 4 hours is important to prevent retention. Obtain an order for catheterization if other measures do not relieve the problem. A medication for urinary retention, we already talked about, uracil. Examples of medication that relieve symptoms produced by benign prostatic hypertrophy or enlarged prostate gland include Flomax, which is tamsulosin or doxazosin, Cardura, or maybe even finasteride or Proscar. These medications help to dilate uh, the urologic um, tubules, right? And they allow a increased excretion of urine. Okay, so that is it for that chapter, chapter 33. If you have any questions, please let me know. And remember to please come to lecture prepared to talk about how different things affect the color of urine. We're going to do a small activity with that in lecture on Thursday. Thank you.